We are finally entering into Module 11, and this is the last module in your training. So we're going to talk about medications commonly prescribed for residents with Alzheimer's and their side effects, the detection and prevention of malnutrition and dehydration. I'm going to remind you a few of those difficult behaviors that we discussed previously. Aggression and anger, anxiety and agitation, general emotional distress, physical or verbal outbursts, restlessness, pacing, wanderings, hallucinations, which is seeing and hearing or feeling things that are not really there, and delusions, a firmly held belief in things that are not true, sleep issues, and sundowning. Now, a common approach to difficult behaviors is to go right to medicating them with tranquilizers, sedatives, or antipsychotics. But that's risky and often not what's best. Experts recommend trying behavior management first, and for good reasons. It tends to be more effective in the long run than, quote, chemical restraints, which are medications, has no dangerous side effects, and leads to a better care relationship. These non-drug approaches to managing behavior symptoms promote physical and emotional comfort, and many of these strategies aim to identify and address needs that the person with Alzheimer's may have difficulty expressing as the disease progresses. Therefore, non-drug approaches should always be tried first. The first class of medications that we're going to look at are the psychotropic medications. They are used at times to treat the behavioral, psychological, and emotional symptoms of Alzheimer's disease. And they have an actual diagnosis. They are referred to as behavioral and psychological symptoms of dementia. The classes of psychotropic medications used to manage the behavioral and psychological symptoms of dementia include antidepressants, anti-anxiety medications, antipsychotics, mood stabilizers, and medications for insomnia, sometimes called sleeping pills or hypnotics. These medications can be effective, but can also potentially cause significant side effects. Psychotropics are typically used in conjunction with other non-drug approaches or after attempting non-drug therapies and finding them to be inadequate. We need to be very careful with our antipsychotic medications. So the decision to use one needs to be considered with extreme caution. Research has shown that these drugs are associated with an increased risk of stroke and death in older adults with dementia. The FDA has even ordered manufacturers to label such drugs with a black box warning about their risks and a reminder that they are not approved to treat dementia symptoms. Antipsychotic medications for hallucinations, delusions, aggression, agitation, hostility, and uncooperativeness are Abilify, Clozaril, Haldol, Zyprexa, Seroquel, Risperdal, and Geodon. I also included the generic names along with them. While there is no cure, prevention, or treatment to slow the progression of Alzheimer's, there are 5 prescription medications approved by the U.S. Food and Drug Administration to treat its symptoms. As Alzheimer's progresses, brain cells die and connection among cells are lost, causing cognitive symptoms to worsen. While current medications cannot stop the damage Alzheimer's causes to brain cells, they may help lessen or stabilize symptoms for a limited time by affecting certain chemicals involved in carrying messages among the brain's nerve cells. Doctors sometimes prescribe both types of medications together. So medications for early to moderate stages. Most of the prescription medications currently approved to treat Alzheimer's symptoms in early to moderate stages are from a class of drugs called cholinesterase inhibitors. Cholinesterase inhibitors are prescribed to treat symptoms related to memory, thinking, language, judgment, and other thought processes. They prevent the breakdown of acetylcholine, which is a chemical messenger important for learning and memory. This supports communication among nerve cells by keeping this level of acetylcholine high. It may also delay or slow the worsening of symptoms, but of course the effectiveness varies from person to person. They are generally well tolerated. If side effects occur, they commonly include nausea, vomiting, loss of appetite, and increased frequency of bowel movements. It is strongly recommended that a physician who is experienced in these medications monitor patients who are taking them and that the recommended guidelines be strictly observed. 3 cholinesterase inhibitors are commonly prescribed. Aricept is approved to treat all stages of Alzheimer's disease. Razodine is approved for mild to moderate stages, and Exelon is also approved for mild to moderate Alzheimer's, but is also prescribed for dementia and Parkinson's disease. Namenda is approved for the moderate to severe stages of Alzheimer's. And there is also another combined medication of Namenda and Aricept that is approved by the FDA for treatment of moderate to severe Alzheimer's. The Namenda, or the memantine, is prescribed to improve memory, attention, reason, language, and the ability to perform certain tasks. It can be used alone or it can be used with other Alzheimer's disease treatments. There is some evidence that individuals with moderate to severe Alzheimer's who are taking a cholinesterase inhibitor might benefit by also taking the Namenda. I most commonly see Namenda prescribed with Aricept. The Namenda regulates the activity of glutamate, a chemical involved in information processing, storage, and retrieval. This improves mental function and the ability to perform daily activities for some people. Now, of course, there are side effects, and the most common are headache, constipation, confusion, and dizziness. So here is a chart with those 5 medications. It includes the generic and the brand name, and also the side effects of the different medications. We're also going to watch a video right now, and what I like about this video, which does repeat a lot of the information that I gave you, but it talks about emerging treatments and research. So let's take a few minutes to watch it.
In this lecture, we are going to cover the pharmacology of drugs used in treatment of Alzheimer's disease. So let's get right into it. Alzheimer's disease is a progressive neurodegenerative disease that leads to symptoms of dementia. The pathophysiology of this disease is quite complex and not entirely understood. However, there are currently few different hypotheses that try to explain the cause of Alzheimer's. The most popular ones include number 1, cholinergic hypothesis, which states that a possible cause of Alzheimer's is the loss of central cholinergic neurons and ensuing deficiency of acetylcholine, a neurotransmitter involved in memory and learning. At number 2, we have amyloid hypothesis, which states that Alzheimer's may be caused by accumulation of abnormally folded beta amyloid proteins. Beta amyloid is a metabolic waste product present in the fluid between brain cells. In Alzheimer's disease, beta amyloid clumps together to form amyloid plaques, which are thought to induce neuroinflammation and disrupt communication between neurons. Lastly, at number 3, we have tau hypothesis, which proposes that Alzheimer's may result from abnormal aggregation of tau proteins that leads to the formation of tangles within nerve cells in the brain. In a healthy brain, the tau protein helps to lengthen and support microtubule structure. Microtubules play a crucial role in transport of nutrients and information molecules throughout the neuron. So when tau dissociates, the microtubule assembly becomes compromised, thereby disrupting the neuron's transport system, leading to malfunctions in biochemical communication between neurons. Now, when it comes to treatment of Alzheimer's disease, current therapeutic options are limited to drugs that provide only mild symptomatic benefit. We can divide those drugs into 2 classes. Number 1, cholinesterase inhibitors, and number 2, NMDA receptor antagonists. So let's talk about these for a minute, starting with cholinesterase inhibitors. Under normal conditions, cholinergic neurons in the brain synthesize acetylcholine from acetyl coenzyme A and choline in a reaction catalyzed by an enzyme choline acetyltransferase. Upon arrival of neuronal impulse, synthesized acetylcholine is released into the synaptic cleft, where it interacts with acetylcholine receptors located on the postsynaptic neurons. Shortly after, two enzymes, acetylcholinesterase and butyrylcholinesterase, break down acetylcholine into acetate and choline, thus terminating stimulating signals. Now, since Alzheimer's has been linked to a deficiency of acetylcholine in the brain, cholinesterase inhibitors were introduced to alleviate the symptoms of the disease. As their name suggests, cholinesterase inhibitors work simply by inhibiting cholinesterase enzymes from breaking down acetylcholine, thereby increasing both the level and duration of action of acetylcholine. The three commonly prescribed cholinesterase inhibitors are donepezil, rivastigmine, and galantamine. It's important to note here that out of the three, rivastigmine is the only one that shows significant inhibition of both acetylcholinesterase and butyrylcholinesterase. When it comes to side effects, they can range from mild, such as nausea, vomiting, and diarrhea, to potentially serious, such as slow heartbeat, lack of appetite, and substantial weight loss. Now let's move on to our next drug class, that is NMDA receptor antagonist. So NMDA receptors belong to the family of ionotropic glutamate receptors, which mediate most of the excitatory synaptic transmission in the brain. They are thought to play an important role in learning and memory formation. Research suggests that beta amyloid proteins that accumulate in the brain of Alzheimer's patients may cause abnormal rise in extrasynaptic glutamate levels by inhibiting glutamate uptake or triggering glutamate release from glial cells. Now, as you may know, the binding of glutamate to the NMDA receptor results in an influx of extracellular calcium, which controls membrane excitability and synaptic transmission. So when glutamate levels become abnormally elevated, overstimulation of NMDA receptors can result, leading to excessive influx of calcium, ultimately causing cell to rupture and die. To address this potential problem, scientists developed NMDA receptor antagonist called memantine, which works by blocking NMDA receptors and thus limiting calcium influx into the neuron. Common side effects associated with memantine include diarrhea, headache, and insomnia. Now, before we end, I wanted to briefly discuss the future of Alzheimer's disease treatments. So, currently available drugs that we discussed so far provide temporary relief of symptoms. However, they do not stop or slow down the underlying neurodegenerative process. This is why new experimental drugs are now being developed to target the root causes of the disease. One of the major promising targets for future drugs is beta amyloid. Researchers are investigating agents that may prevent beta amyloid fragments from clumping into plaques by targeting two enzymes, beta secretase and gamma secretase, which sequentially cut the amyloid precursor protein to generate the pathological beta amyloid peptides. In another approach, researchers have also been testing antibodies that bind to beta amyloid and enhance its clearance from the brain. The second major target of future therapies is tau protein, the main component of tangles. Just like with beta amyloid, antibodies capable of binding and clearing pathological tau proteins are currently being developed and tested. Another area of extensive research involves compounds that prevent tau aggregation or dissolve existing aggregates, as well as compounds that inhibit microtubule disassembly. Now, despite all the optimism surrounding a large pipeline of drugs in clinical trials, so far the field of Alzheimer's research has been filled with disappointments, as many promising drugs have failed to show significant improvement in slowing down the progression of the disease. However, there's always a lot we can learn from failure, and with every failed trial, we find out more about the disease and what might work to stop it.
Now we're going to talk about hydration. Staying properly hydrated is an ongoing, repetitive process of taking in fluids several times a day. This is a general issue for the elderly, but Alzheimer's patients face several unique factors that can put them at even higher risk for dehydration. They can have an inability to recognize the sensation of thirst. Alzheimer's eventually affects every part of the brain, and the one that recognizes the sensation of thirst is no exception. An older adult in this situation may experience a sensation of discomfort, but might not be able to determine the cause. Even if seniors with Alzheimer's experience and understand the sensation of thirst, memory loss may cause seniors to forget where they put their glass of water or that they even poured it. It's not uncommon for caregivers to discover several full cups scattered around the home. Difficulty swallowing. In addition to affecting the brain's ability to recognize thirst, Alzheimer's can also diminish its ability to control mouth and throat muscles, making swallowing difficult. Seniors may be reluctant to drink if they fear choking. Prescription medications. Some drugs commonly prescribed to seniors have the side effect of increasing urination, which increases the need to take in more fluids to compensate for those being expelled. Mobility challenges. Many seniors with Alzheimer's have additional physical conditions that limit their mobility. Those who use a wheelchair or walker may not be able to easily access a cupboard, refrigerator, or sink. Also, a fear of incontinence. Decreased bladder control may keep many seniors, even those without dementia, from drinking as much as they should. Ironically, dehydration causes salts and proteins to build up in the urine, exacerbating incontinence. Dehydration happens when the body doesn't have as much water as it needs. Without enough, a body can't function properly. It worsens constipation, increases the risk of bladder infection and kidney injury. It can aggravate asthma or lung conditions and reduces mental performance and increases fatigue. Mild dehydration symptoms include dryness of the mouth and a dry tongue, dark or deep yellow urine, headaches, crying but with few or no tears, weakness or a general feeling of being unwell, sleepiness or irritability. More serious dehydration symptoms include low blood pressure, convulsions, severe cramping and muscle contractions in the limbs, a rapid but weak pulse, dry and sunken eyes with few or no tears, breathing faster than normal. A good formula for how much water is needed every day is to take about 1/3 of the person's body weight in pounds and drink the equivalent number of ounces of water daily. For example, a 150-pound woman would need 50 ounces of water daily, or about 6 8-ounce glasses of water. And the best and easiest way to assess for proper hydration is the color of the urine. It should be a clear or a pale yellow, not a dark yellow or an amber color. Although it can be challenging to keep an elderly loved one with Alzheimer's hydrated, here are 5 strategies that may prove effective. Prompt them to drink often. There's nothing wrong with asking your loved one to take a sip or 2 of water every half hour. Frequent small drinks will eliminate the need to take larger drinks. This can be especially helpful for seniors who have difficulty swallowing. Eliminate as many challenges as possible. Seniors and Alzheimer's patients with arthritis, muscle weakness, or other health issues may find it difficult to grip a cup or even bring a full glass to their lips without spilling, making them reluctant to drink. Smaller, no-spill cups can improve confidence. One-way straws can also help. There are many models designed with adults in mind with no cartoon characters or other markings that would label it a sippy cup. Provide their favorites. Although water is always a good choice for hydration, it's not the only one. Those with Alzheimer's often prefer more flavorful options, especially sweet ones. So sports drinks with a low sugar content and Pedialyte not only provide taste, but also salts, minerals, and electrolytes. Watered down fruit juices are also another possible alternative, as well as flavored water. Don't forget foods that are high in water content. 20% of an average adult's fluid intake comes from foods. So watermelon, cucumber, celery, berries, and yogurt are actually all very hydrating, as are grapefruits and even soft cheeses. And recognize the early signs of dehydration. The sooner you realize your loved one may be dehydrated, the sooner you can take action. Again, those early signs include chapped lips, constipation, decreased urine output, dry skin. One tried and true method of determining whether or not somebody is hydrated is the Turgor test. So gently pinch the skin on the back of your hand between your thumb and finger. If the skin remains tented for more than a few seconds, it's an indication of dehydration. Let's move on to nutrition. Regular nutritious meals may become a challenge for people with dementia. As a person's cognitive function declines, he or she may become overwhelmed with too many food choices, forget to eat, or have difficulty with eating utensils. Proper nutrition is important to keep the body strong and healthy. For a person with Alzheimer's or dementia, poor nutrition may increase behavioral symptoms and cause weight loss. People with Alzheimer's or dementia do not need a special diet, and as with anyone, eating a well-balanced, nutritious diet is important for overall health. So some nutrition tips would be to prioritize consumption of whole foods to increase nutrition. This includes fruits and vegetables, beans, meat, poultry, fish, dairy products, eggs, nuts, seeds, and whole grains. Focus on soft, well-cooked or pureed blended foods. Try scrambled eggs or poached fish, mashed potatoes, avocado, yogurt, smoothies, soups, because those are easier to digest. Try food supplements, so protein powders or drinks can be helpful to their nutrition, and there are many products out there. Aim to create balanced meals. These should have a protein source, a colorful fruit or veggie, a healthy fat, and a quality carbohydrate at every meal. If the budget allows, sign up for a grocery or meal delivery service. This can make food preparation much easier. Choose quick and easy to prepare foods when grocery shopping. Opt for pre-made high-quality soups, pre-cut fresh or frozen fruits and vegetables, or pre-cooked proteins. Don't forget pleasure. Look for ways to increase enjoyment while eating. Choose foods that appeal. Set the table with nice linen, silverware, and flowers. Eat slowly and savor food. And allow small treats if desired. A small bowl of vanilla ice cream with hot fudge on it after dinner a couple times a week makes life just a little bit more delicious. As the disease progresses, loss of appetite and weight loss may become concerns. In such cases, the doctor may suggest supplements between meals to add calories. Make meal times easier. During the middle and late stages of Alzheimer's, distractions, too many choices, and changes in perception, taste, and smell can make eating more difficult. The following tips can help. Limit distractions. Serve meals in quiet surroundings away from the television and other distractions. Keep the table setting simple. Avoid placing items on the table, such as table arrangements or plastic fruit that might distract or confuse the person. Use only the utensils needed for the meal. Distinguish food from the plate. Changes in visual and spatial abilities may make it tough for someone with dementia to distinguish food from the plate or the plate from the table. It can help to use white plates or bowls with a contrasting color placemat. Avoid patterned dishes, tablecloths, and placemats. Check the food temperature. A person with dementia might not be able to tell if something is too hot to eat or drink. So always test the temperature of foods and beverages before serving. Serve only one or two foods at a time because too many foods may be overwhelming. Simplify by serving one dish at a time. For example, mashed potatoes followed by the meat. Be flexible to food preferences. Keep long-standing personal preferences in mind when preparing food, and be aware that a person with dementia may suddenly develop new food preferences or reject foods that were liked in the past. Time. Always give the person plenty of time to eat. Remind him or her to chew and swallow carefully. Keep in mind that it may take an hour or longer to finish eating. Eat together. Make meals an enjoyable social event so everyone looks forward to the experience. Research suggests that people eat better when they are in the company of others. Keep in mind the person may not remember if he or she ate. If the person continues to ask about eating breakfast, consider serving several breakfasts, so juice followed by toast, followed by cereal. And encourage independence as much as you can. During the middle and late stages of Alzheimer's, allow the person with dementia to be as independent as possible during meals, but be ready to help when needed. Make the most of the person's abilities. Adapt serving dishes and utensils to make eating easier. You might serve food in a bowl instead of on a plate, or try using a plate with rims or protective edges. A spoon with a large handle may make it less difficult to handle than a fork, or even let the person use his or her hands if it's easier. Serve finger foods. Try bite-sized foods that are easy to pick up, such as chicken nuggets, fish sticks, tuna sandwiches, orange segments, steamed broccoli, or cauliflower pieces. Use a watch me technique. For example, hold a spoon and show the person how to eat a bowl of cereal. And don't worry about neatness. Let the person feed him or herself as much as possible. It might be helpful to get plates with suction cups. In the middle and late stages of Alzheimer's, swallowing problems could lead to choking and weight loss. Be aware of safety concerns and try these tips. Again, prepare foods so they aren't hard to chew or swallow. Grind them, cut them into bite-sized pieces, or simply serve soft foods like applesauce, cottage cheese, or scrambled eggs. Be alert for signs of choking. Avoid foods that are difficult to chew thoroughly, like raw carrots. Encourage the person to sit up straight with his or her head slightly forward. If the person's head tilts backwards, move it to a forward position. At the end of the meal, check the person's mouth to make sure food has been swallowed. And learn the Heimlich maneuver to use in case of an emergency. Address a decreased appetite. If the person has a decreased appetite, try preparing favorite foods, increase physical activity, or plan for small, several meals rather than 3 large ones. If the person's appetite does not increase or he or she is losing weight, consult with the doctor. Keep in mind, as the person's activity level decreases, he or she may not need as many calories. And only use vitamin supplements on the recommendation of a healthcare provider. In conclusion, although the human and societal cost of Alzheimer's disease is staggering, there is hope that earlier and better diagnosis, increased knowledge of its natural history with support of the patient and family throughout the disease stages, effective symptomatic drugs, and potentially effective disease modification strategies will have a dramatic impact on the number of persons affected in the future and the quality of life of persons currently affected. The fast pace of research and the development in Alzheimer's is unique in neurological history and should lead to a better future for aging populations. I'd like to end with my own personal experience about Alzheimer's. When my son was born and we moved back to Michigan, I would visit my grandmother with my son about every 1 to 2 weeks. We would make a day of it. My son would sit on her lap in the wheelchair. We would walk across to the park when the weather was nice, or we would sit next to the creek. We'd feed the ducks. He would eat her food, play with her jewelry, and they were basically on the same cognitive level. And honestly, we had a lot of fun. Now, she didn't remember my name. She didn't remember her children's names. She didn't remember her grandchildren's names, but she would always remember and ask about that little boy, even when others visited her. Now, as her Alzheimer's disease advanced, I would often think about just the sadness of the decline in her quality of life. Yet that time in her life significantly impacted the life of my son. He would insist on feeding her. And I remember one time he even made one of the nurses cry. I turned around and I saw her crying and she said, "That is so sweet." And he wasn't even fazed by the different sights and the different smells of her unit. He enjoyed her company. 2 weeks before she died, when he was about 5 years old, I remember we were walking in the courtyard. She was in this chair that leaned her back. She couldn't talk. She basically couldn't do anything, and he insisted on holding her hand the whole time. On the day she died, we went to the home, and my mother gave him her jewelry box. He held onto that box for about the next week, and he would not let go of it. And I believe it was his way of processing her death. So my point in sharing the story is that even in the late stages of the disease, there was still a purpose for her life. And I just pray that we would all keep that in mind. And whether we are caring for patients with Alzheimer's or going through this with our family members, there is still a purpose in their lives.